Hi there, my name is Victoria Lacey and I'm going to be talking to you today about cognitive therapy for depression. This treatment was developed by Aaron Beck, and I'd strongly recommend that alongside this course you purchase the book and read it, because it's going to give you the depth and breadth that this course maybe won't go into. However, the bonus about this course is that I've been doing and practicing this treatment intervention for some time now, so I'll be able to give you a real life version of it and hopefully translate it a little bit for you. So have a look at Aaron Beck's book, Cognitive Therapy for Depression. His daughter Judith Beck has written another book around cognitive therapy for depression, which I'd say is a little more, feels a little bit more modern, and it feels a little bit more down to earth as well. So you can dip into that too. So what we're going to cover in this course is I'm going to introduce you to cognitive therapy for depression. We're going to be looking at assessment skills, mainly around building that therapeutic relationship, which is so important to have when you're doing cognitive therapy. I'm going to show you a typical outline of the therapy session so that you can get a sense of actually what it looks like in real terms. We're going to look at behavioural techniques and cognitive techniques, and I'm going to help you to spot and work with those rules and assumptions that will come up during treatment. As part of this treatment intervention, I do want to talk to you about specific techniques for suicidal patients, and they can be used where perhaps it's not quite appropriate to send them to specialist services, which would always be your first port of call. And finally, we'll end up with therapeutic challenges. So what is cognitive therapy and what is it based on? So for Beck, cognitive dysfunction is the core symptom feature of depression. So we need to be careful here, because he's not saying it's the cause of depression, but it is the core feature. Now, Beck says that that depressed affect is linked to the triggering of latent schema or core beliefs. I'm going to use schema and core beliefs interchangeably, as you'll see in many different texts. So it's triggering that latent schema, and that relates to things like personal loss, failure and dysfunction. And if you think about it, you'd be really lucky not to experience any of those in life. So if you have latent schema that are perhaps vulnerable to those areas, then perhaps you would be more likely to experience depression. Now, cognitive dysfunction is seen as a continuum rather than an absolute. It's not that you're depressed or you're not. It's more about degrees. Now, if we think about the implication that this has for therapy, it's that for a patient who has experienced depression, no matter how severe that is or how bad their cognitive dysfunction is, they will always have some ability, some flexibility and adaptability in their cognitions. And as a cognitive behavioural therapist doing cognitive therapy, it's up to you to really tap into that and harness those skills into offering, into sort of changing the way that you think and the way that you behave, and developing those coping mechanisms for managing depression. Now, when it comes to recurrent depression, so that is someone who experiences multiple episodes of depression periodically throughout their life. Now, Beck says that this causes that threshold to weaken, and you're more likely to trigger those problematic core beliefs again and again, so more often through your life. So what are these cognitive dysfunctions and what do they look like? Well, these are, in other words, negative beliefs or attributions. For example, if I don't get an A, this means that I am stupid and I won't get a good job. Now, as you can see from that example, those beliefs or attributions are often really quite extreme rather than being balanced. If you imagine the belief, if I don't get a C grade and then not all options will be open to me, but I could still get a good job, who do you think would feel better about getting, say, a B plus? Yeah, so the second one. I mean, a B plus is not a bad grade. I think, it's about, I suppose, reaching and trying hard, but when it's about treating someone with depression, we're looking for ways to help a person think in a much more balanced way, not in extremes. So these cognitive dysfunctions may include a negative view of self. For example, I am unlovable or I am worthless. And they also include a negative interpretation of events. So my friend said they were really busy this weekend. They obviously just don't like me. Now, just to take a moment to imagine how you would feel if this was the way that your mind thought automatically. It would be pretty tough, wouldn't it? I think it would. So there may also be cognitive distortions such as overgeneralizing. For example, I was anxious about saying my name on the first day of school, so I'm going to feel anxious about talking in school all of the time. Another example is catastrophizing. For example, I made a spelling mistake in my email to my boss. I'm going to get fired, or my boss will think I'm really incompetent. And then another example is black and white thinking. So one bad thing happened today and now my whole day is ruined. Again, just take a moment to imagine how you would feel if that was the way that your mind automatically thought. Pressured? Sad? Stressed? Worthless? Unlovable? So these are cognitive dysfunctions that you will learn to spot in your patients. And cognitive therapists will work with these and may perhaps get to work with schema or core beliefs later, but not always. So what are schemas? So Gottlieb and Hammond 1992 say that they are stable characteristics of personality that cause depression by distorting the selection, encoding, organisation and evaluation of environmental stimuli. The best way for you to think about this is a bit like when you're going somewhere on autopilot and you don't have to give it any thought. So schema will colour exactly how you think and behave if you're in autopilot in that moment. Okay, and Beck describes these schemas as latent. So this means that they sit underneath the surface. Perhaps not always prominent or even discernible, but at times quiet. And they rear their head, I suppose, when triggered in the form of cognitions and images. So think of them like lava bubbling away underneath the surface. And it's only when you get the trigger, so the event that happens, and the lava kind of comes to the surface and spews at the top of the volcano. So they're your thoughts and images. So that's a bit like how schema work. Now, just to go a little bit further into this concept, depressed people also have a processing bias. So what this means in real terms is that so evidence shows us that people experiencing depression have a negative bias towards how they evaluate themselves, their predictions for the future success, stuff like that. And their perception of situations might be distorted to fit with that negative view, and this is known as confirmation bias. And it's all of this cognitive dysfunction that will funnel into your affect, so how you feel, and your behaviours, so what you do. Now, Beck's theory was that schema was formed from very early experiences. So if you were raised by perhaps highly critical parents, you may well have schemas that fit with that. In the next chapters, we're going to explore exactly how you're going to identify these and work with them to help your patient to change them. I'm really excited about this. I think you're going to love it. I'll see you in the next chapter. Thank you.